Tokyolive
Tokyolive
Endoscopy
Endoscopy
number one.
1.
Greetings, everyone. Welcome to another session of Tokyolive 2022. I am Raina Fujioshi. Co-moderating this exciting session is Dr. Anastasios Manolakis. We have invited two distinguished speakers for today's session entitled The Role of Endoscopy in Inflammatory Bowel Disease. Let us start the session with our first speaker. It is a great pleasure to introduce Dr. Samir Grover. Dr. Grover is a clinician educator in the Division of Gastroenterology at St. Michael's Hospital and an associate professor in gastroenterology in the Department of Medicine of the University of Toronto, where he serves as the divisional program director. He is also one of the supervisors for the Advanced IBD Fellowship at St. Michael's Hospital. To give us a talk on the endoscopic scoring systems in IBD and its importance, let us all welcome Dr. Samir Grover.
Thank you very much, Dr. Fujioshi, for the kind introduction. And thank you, colleagues, for inviting me to speak today. It's my pleasure to speak about endoscopic scoring systems in inflammatory bowel disease, a highly relevant talk with respect to categorizing disease activity in inflammatory bowel disease and identifying endpoints for therapies, particularly biological medications. These are my disclosures. I'll leave them on the slide for a few seconds so you have a chance to read them. So the definition of disease activity in inflammatory bowel disease has traditionally been ascertained by clinical grounds. Patients will have symptoms that have been used to develop scoring aids for disease activity. Even physical examination findings have been used to establish complications. Laboratory tests assess for complications such as anemia, albumin for assessment of nutritional status, and biochemical markers like C-reactive protein and sedimentation rate for disease activity, as ascertained by inflammation serologically. Fecal calprotectin has emerged as a marker for inflammation inside the stool. But despite this all, endoscopy remains the standard for mucosal assessment in inflammatory bowel disease. And the reason for this is that our understanding of what defines control in inflammatory bowel disease has shifted. And this is a slide that's commonly used in inflammatory bowel disease presentations around biologics from Colin Bell's review from gastroenterology in 2017, describing two phenomena. Number one, there is a new understanding of how inflammation, particularly subclinical inflammation, may actually change the disease course to one that will lead to potentially more complications in both ulcerative colitis and in Crohn's disease. And two, potentially intervening upon this, and part and parcel of that is defining subclinical inflammation as endoscopic evidence of inflammation, even if there are no symptoms, may lead to the opportunity to present therapies that can alter the course of disease long-term. All of this has led to a visual marker like endoscopic evaluation becoming a critical part of disease activity assessment in both Crohn's disease and ulcerative colitis. So today we'll discuss commonly used rubrics for the categorization of disease activity in ulcerative colitis and Crohn's disease, such that there can be a systematic way of defining what these elements are, following them in patients, and of course using them for research applications. And then we'll discuss how healing of the mucosa, as defined as the absence of ulceration in Crohn's disease and the resolution of friability and ulceration in ulcerative colitis, is now being used as an endpoint for disease management. So starting with ulcerative colitis, the most commonly used score for the assessment of endoscopic activity is the endoscopic component of the Mayo score. This is the Mayo Clinical Score. It is a clinical and endoscopic score for disease assessment in ulcerative colitis. It consists of 4 measures. 3 of them are clinical. The first is stool frequency per day, as defined on the slide. The second is rectal bleeding. The third is findings on endoscopy, as graded from 0 to 3, and we'll go through these in 1 second. And finally, there's a physician global assessment from 0 to 3 as well. As mentioned, the endoscopic subscore has a 4-point scale, 0 being normal, 1 being erythema and mild friability, 2 being moderate friability and erosions, and 3 being spontaneous bleeding and ulcerations. And this is a slide that depicts some of these graphically, and we're going to go through some videos. This slide is from Marietta Iacucci. Taking a look at the left, one sees various examples of what mucosal healing or absence of inflammation can look like. And as you notice in the top left and the bottom left, the images are somewhat different from an endoscopic standpoint. The top left is from an individual who has ulcerative colitis, who has not had any evidence of any chronic disease-related complication at the level of the mucosa and has achieved mucosal healing, wherein the mucosa, the vessels, and the surface look exactly like if an individual had never had ulcerative colitis. Whereas in the bottom left, one sees a pattern that is distinctly different. There is a reticular pattern of whiteness that's present. There's some element of neovascularization present. However, this would still remain within the confines of what would be defined as mucosal healing as an endpoint. The images from the second column represent mild disease, and one can see that there is a decrease in the vascular pattern. There may or may not be the presence of small amounts of mucopus. One can see on the top image that there are small white flecks indicative of pus, whereas that's not present in the other two images. Erythema, and particularly punctate erythema, tends to be a pattern that's seen in score 1. In score 2, in the third column, one sees moderate disease, wherein there is markedly more erythema present than the smaller amounts in number 1. The vascular pattern is entirely absent, and one sees that there are erosions that are present. And these progressed in score 3 to severe disease, where spontaneous bleeding is the key phenomenon. Here's some videos that are going to depict the same thing. This is a video of subscore 0, where one sees that the mucosa appears to be entirely normal with a normal vascular pattern and no evidence of any of the inflammatory features that I mentioned. This is a video of Mayo endoscopic score 1, where one sees the vascular pattern is now a little bit altered. One sees the little white flecks of mucopus that I had mentioned before, and one sees, as this progresses, small amounts of erythema that will be present. For subscore 2, the inflammatory pattern is now markedly more evident. One sees that there is no vasculature seen whatsoever. Very clearly, one sees the presence of inflammation by the erosions that are clearly visible on the mucosal surface. And now for Mayo endoscopic score 3, there's this one is, I think, limited by biopsies that have already been done, but in typical, there is spontaneous bleeding that's seen at the time of insertion of the endoscope and the presence of ulcers that are quite evident at the time of insertion of the scope. Now, defining mucosal healing has been how this endoscopic subscore has proven to be most useful. Mucosal healing is defined by the STRIDE consensus as a subscore of 0 to 1. And this data of why this is an important depiction comes from post hoc analysis of the ACT-1 trial, which was the infliximab trial for management of ulcerative colitis for induction. And if you take a look at those patients over time, the post-treatment endoscopic score of 0 to 1 had colectomy rates that were significantly less with time than individuals who had higher scores that were present, independent of symptoms being present. And this is highly suggestive of the fact that endoscopic evaluation, independent of clinical evaluation, has a hard benefit with respect to outcome of complications in ulcerative colitis. Now, there are other scores that have been used both in research as well as clinically. The ulcerative colitis endoscopic index of severity is commonly used in research. It's an easy to use scale wherein 3 endoscopic findings, vascular pattern, bleeding, erosions, and ulcers are scored, and it's scored in the most severely affected part of the colon. It's very simple to use in clinical practice. It divides things into mild, moderate, and severe disease, although those definitions are not as distinctly defined as it is in the setting of the Mayo endoscopic score. In Crohn's disease, there are 3 endoscopic scoring systems that are used. 2 of them are used with respect to individuals with Crohn's disease and assessing endoscopy, and one is the Rutgeert score, which is used specifically for ascertaining for post-operative recurrence in the neoterminal ileum. I'll go through these in brief. The Crohn's disease endoscopic index of severity is a rather complicated scale wherein a total score of 44 is scored from 5 bowel segments: the terminal ileum, the right colon, transverse colon, left colon, sigmoid colon, and rectum. It's what was used previously as the primary standard in terms of defining endoscopic disease in Crohn's disease in the literature. However, it is challenging to use. It requires expertise in determining whether ulceration is present and whether distinguish that from erosions, and to determine the percentage of mucosal surfaces that are involved. From this evolved the simple endoscopic score for Crohn's disease, which is much simpler to use and can actually be used clinically, wherein 4 variables are used only in those 5 segments of the bowel that I defined before. The first is maximum ulcer size. The second is percentage of ulcerated surface. The third is percentage of any affected surface. And the fourth is the presence of stenosis that's present. And I'll show these from video form as well. This is an individual with a simple endoscopic score in Crohn's disease of 12, wherein one can see that there are ulcers that are present. One takes the maximum size of the ulcer to define things, and in this rubric, it gives you a score of 3. The percentage of the ulcerated surface would give a score of 3. The percentage of the affected surface would be 3, and the presence of stenosis here would give a score of 3 as well. We know the simple endoscopic score correlates better with the better validated Crohn's disease endoscopic index of severity. And endoscopic remission is defined as a 50% decrease in the simple endoscopic score. The Rutgeert score is commonly used in post-operative Crohn's disease, and it's meant to evaluate the neoterminal ileum and has been the standard for predicting the prognosis of post-operative recurrence, and indeed has been used in order to define whether therapies are required even in the asymptomatic patient. A Rutgeert score of I0 indicates that no disease is present in the neoterminal ileum. A Rutgeert score of I1 indicates low numbers of aphthous ulcers, and one saw the aphthous ulcer in this video over here. A score of I2 is associated with larger ulcerations on the neoterminal ileal side of the anastomosis. A score of I3 shows aphthous ulcers in the ileum and even larger ulcers that are present, which extend to the level of the anastomosis. A Rutgeert score of I4 is associated with a strictured anastomosis where one is unable to access the neoterminal ileum. A Rutgeert score of I0 or I1 is indicative of a low risk of clinical recurrence, and I would view that as evidence of the equivalent of mucosal healing inside the post-operative patient with Crohn's disease. So why is this important? The International Organization of Inflammatory Bowel Disease has a consensus statement termed the Selecting Therapeutic Targets in Inflammatory Bowel Disease consensus statement based on large systematic reviews that were performed in 2015 and presented in 2021 most recently. And these identify what the goals are for therapy in inflammatory bowel disease: clinical, laboratory, endoscopic, histologic. Objectively, in broad strokes, the clinical goals are resolution of symptoms, but mucosal healing independently is associated with improvement in clinical response. This is the diagram from the STRIDE paper from 2021 that shows what exactly the thresholds are from clinical response to remission, to biochemical remission, to endoscopic healing, and potentially to histologic healing as a long-term target. In ulcerative colitis, achieving mucosal healing, namely a Mayo endoscopic score of 0 to 1, improves long-term clinical outcomes with long-term clinical remission at 52 weeks and avoiding colectomy at an odds ratio of 4.5 with respect to clinical remission and 4.2 for avoiding colectomy at the 1-year mark. Exceptional. So this is independent of any clinical indices. Indeed, even within endoscopic scores of 0 to 1, there can be a difference where treatment to an endoscopic score of 0, complete mucosal healing, may be associated with decreased risk of relapse as well as recurrence-free survival in 2 studies, one by Barriero et da Costa and one by Bol Carvalho, demonstrating the fact that there is substantially decreased risk of clinical relapse even within that threshold of 0 to 1. Furthermore, individuals who have a Mayo endoscopic score of 0 have higher rates of steroid-free remission than individuals with an endoscopic score of 1. In Crohn's disease, this has been demonstrated as well. 69% of individuals with Crohn's disease in one large post-hoc analysis of biological therapies at initial assessment after starting medical therapy achieved long-term clinical remission compared to 43% without mucosal healing, even if clinical markers and clinical symptoms were identical. This is from the Ibsen group. This is older data from 2007 showing that individuals requiring, this is individuals who, a Kaplan-Meier curve to determine whether individuals would require surgery in Crohn's disease with years over time, using mucosal healing at the 1-year mark as the assessment, showing that if you were to achieve mucosal healing in Crohn's disease at the 1-year mark, there's a significantly decreased risk of the need for surgery at the endpoints that have been demonstrated here. There's now numerous studies demonstrating how similar phenomena take place, where first endoscopic assessment demonstrating mucosal healing is associated with long-term clinical remission. This is a systematic review, meta-analysis with the forest plot depicting this on the top for clinical remission, and at the bottom, the lesser amount of data for Crohn's disease-related surgery-free rate. And if you take a look at the pooled analyses with respect to this, one sees that the evidence for mucosal healing over partial mucosal healing for hospitalization is improved as well. But what about histological healing? So if endoscopic healing is an endpoint that's of importance, surely if one takes a physical biopsy and demonstrates the fact that there's normalization at the level of the cell, perhaps this would be potentially associated with a decreased rate of clinical relapse as well. This has been demonstrated in one database study showing that individuals with histological normalization of the mucosa and ulcerative colitis are associated with an increased rate of clinical response than those that do not have normalization of the histology. Now, there are limitations in the use of mucosal healing as a therapeutic endpoint. In Crohn's disease specifically, there have only been a few studies that have evaluated whether mucosal healing is useful for a therapeutic endpoint and also for other applications beyond just the endpoints that I mentioned, decreased surgery. There's many other clinically important endpoints in Crohn's disease. And finally, the timing of the assessment of mucosal healing has really not been validated in terms of showing when healing takes place with particular biologic therapies, with some studies evaluating this at 6 months, 9 months, and 1 year. In summary, treating inflammatory bowel disease beyond symptoms now involves the use of not just patient-reported outcomes, but assessment using endoscopic activity and biomarkers. The endoscopic mucosal healing specifically associates with sustained clinical response and reduced morbidity. And endoscopic scoring systems allow you to provide objectivity, uniformity, and standardization of reporting. And despite being somewhat limited by their complexity and some lack of validation for scores, their strength lies in being able to provide an objective tool to augment clinical decision-making on the assessment of endoscopy and inflammatory bowel disease. This is our group in Toronto. Thank you very much for allowing me the chance to present.
Thank you very much, Dr. Grover, for this very informative lecture. I think I understand that the role of endoscopy in assessing the disease activity in IBD is of paramount importance, especially when it comes to treatment strategies. I just have one question. So beyond endoscopic healing, the threshold for healing of the mucosa in ulcerative colitis could be histologic healing. So should we be treating to a histologic remission in ulcerative colitis?
Thank you, Dr. Fujiyoshi. For histologic healing as an endpoint, it sort of makes sense that if endoscopy shows that things improve and that can occur at a subclinical level, surely histology would be the next branch off to that, that if you have subclinical histological healing, patients may potentially do better in ulcerative colitis. There are indices that have been used for assessment of histologic activity in ulcerative colitis, the Giebo's index, the Nancy index, and the Robarts clinical index being the most commonly used one. And there is evidence, albeit weak evidence, showing that individuals that have histologic healing in ulcerative colitis improve with respect to clinical response after a shorter period of time. But the bulk of the evidence behind this is limited to post hoc analyses of studies of biological therapies as well as registry level data. And more significant data is required in order to reach that conclusion, in order to use it as a hard endpoint.
Thank you. And Dr. Manolakis, if you have a question.
I would like to congratulate Professor Samir Grover for his lecture. It was a fantastic presentation. I really enjoyed it. Just a short question. The problem with endoscopic classifications and relevant score is that although we claim that they are reproducible and easily reproducible, there is an inter-observer disagreement. So you think that we can make it on our own, or do we need something extra, such as artificial intelligence, combining, I don't know, probably different biomarkers as well, endoscopic images, stills, or videos to help us to come to our aid?
Thank you, Dr. Manolakis. So extremely cogent question that you've asked. First of all, the inter-observer reliability of these indices is, if you take a look at the studies for CDEIS in particular, the study from Robarts clinical trials showed moderate inter-observer reliability with respect to the CDEIS score, which led to the development of the simpler SES score that I mentioned, that has allowed for a more usable and practical alternative. But the question of whether machines can be doing this better than humans is something that's currently under evaluation. So there's, last time I checked, there's 7 prospective trials using still images and video of various machine learning neural network strategies in artificial intelligence compared to humans. There's several retrospective studies taking a look to see whether disease activity as assessed by convolutional neural networks is improved compared to whether humans are able to do it. So this is certainly an emerging field, and I think while the timing for optical biopsy for disease activity hasn't come yet, it surely and rapidly will be here in the future.
Thank you very much once again, Dr. Grover. I would now like to give the floor, or the screen rather, to my co-moderator, Dr. Manolakis.
Thank you very much, Reina. So it is with great pleasure that I ask to introduce Dr. Kostas Argyriou. He is a consultant gastroenterologist and academic staff at our department, the Department of Gastroenterology, University Hospital of Larissa, Greece. He's been trained by experts in Lincolnshire, Birmingham, and Nottingham Digestive Disease Center, United Kingdom, and he is currently our IBD expert. So I welcome you, Dr. Kostas Argyriou. Kostas, in Tokyolive 2022, and we eagerly await for your presentation. Please, the floor is yours.
Yeah. At first, I would like to thank Professor Manolakis for this kind introduction, and to congratulate Professor Grover for the excellent talk that he just gave us the pleasure to see. And but prior to start my own presentation, I would like to thank the organizing committee of the Tokyolive and personally Professor Haruhiro Inui for the kind invitation to participate in this global event. As Professor Grover said, endoscopic evaluation is essential to achieve current therapeutic goals in inflammatory bowel diseases. And my speech will be regarding the endoscopic management. Given that we have only 10 minutes at our disposal, I'll quickly share my screen. So I'll take things from scratch. I will repeat everything. So at first, I would like to thank Professor Manolakis for the kind introduction and Professor Grover for the previous really thought-provoking lecture on the traditional endoscopic scopes that we have in IBD and the limitations that they have in our clinical practice. But above all, I would like to thank all the organizing committee and profession, and personally Professor Inouye for the kind invitation to participate in this event. My part refers to the endoscopic management of IBD. I will quickly start. Endoscopic evaluation, as Professor Grover said, is essential to achieve current therapeutic goals in IBD. However, in the absence of a definite treatment, IBD progressively leads to various debilitating disorders and complications, including strictures, fistulas, abscesses, and of course, cancer. Available medical treatments have been found to be less effective in managing IBD related complications, whereas surgery, although it can offer an immediate relief, it has been associated with postoperative complications and disease recurrence. Therapeutic endoscopy is expected to bridge medical and surgical treatments in the management of IBD, and hence is of particular importance. Within the next minutes, I'm going to give a brief description of the different endoscopic modalities that can be currently employed in the management of IBD. As you already saw, I have no conflict of interest to declare relevant to this presentation. To date, the role of therapeutic endoscopy in the management of IBD has been explored in 4 main areas that include management of first disease-related adverse events such as strictures, fistulas, abscesses, and of course neoplasia, and of IBD surgery-associated complications such as acute and chronic leaks and strictures. More specifically, in the management of strictures, endoscopic therapy is regarded as the first line of treatment. Currently, 3 are the main endoscopic treatment modalities that currently exist. First is the endoscopic balloon dilation, the endoscopic needle knife stricturotomy or stricturoplasty, and the use of endoluminal stents. Modality selection depends on several factors, such as the length, the location, and the complexity of the stricture, with most strictures being easily approached by standard endoscopes, as the one that we use, since they are located in the distal ileum, the ileocecal valve, the colon, the ileocolonic anastomosis, the ileorectal anastomosis, and the ileal pouches. However, irrespective of the modality that will be finally employed, the aims of endoscopists are to achieve 2 things. First of all, the immediate passage of the scope, and secondly, the longest possible reintervention and surgery-free survival for each of our patients. For the endoscopic balloon dilatation, we generally use balloons of 15 to 20 millimeters that exert blunt mechanical force in the stenosed area. However, smaller balloons can be also used for the same purpose effectively. Depending on endoscopy decision, the procedure can be performed in many ways, including retrograde or anterograde dilations, under direct view during the balloon insufflation, with wire exchange or wire out, with or without intralesional injection of long-acting steroids or anti-tumor necrosis factors. In our department, as shown in this photo series, for all IBD strictures, we prefer to perform retrograde or anterograde dilations under direct view always of the balloon, so as to immediately identify and treat potential procedure-related complications. With regards to efficacy, current evidence suggests that balloon dilation can delay surgery up to 5 years, with 73% of the population require another dilation within the first 2 years in order to preserve the positive outcome, which apparently makes balloon dilation an effective procedure. At the same time, with regards to safety, adverse events occurs in up to 15% of cases, with bowel perforations occurring in 9% of them, establishing a relatively safe profile for the referring modality. However, all IBD strictures are not amenable to balloon dilations. Short and single strictures have been found to be easily treated with this modality, but for multiple long or angulated strictures with prestenotic luminal dilatation, or for those associated with fistulas or abscesses, surgery remains the modality of choice. Endoscopic stricturotomy and stricturoplasty emerge as an alternative modality to balloon dilations for the management of short IBD strictures. Both modalities involve the electroincision of the targeted tissue and present two major advantages compared to balloon dilation. First, these modalities allows endoscopists to fully control the depth and the topography of cutting, and second, they enable various fashions of cutting, such as radial, horizontal, and circumferential cuts that can minimize the risk of iatrogenic injury to adjacent structures, such as the anal sphincter or adjacent vagina, in cases where we have to treat distal bowel or anal strictures. Hence, it's of no surprise that these modalities are currently preferred as first-line therapy for the management of short fibrotic strictures. In this photo series, you can see a case of endoscopic stricturotomy that was performed in our department in an IBD patient with an anastomotic stenosis. Subtle ischemic changes were present at the stenosed area, covering approximately 50% of the circumference of the lumen. The procedure was performed by Dr. Manolakis and initially included 3 radial electroincisions with insulated tip knife for better control. Circumferential debridement followed till the final resolution of the stricture, with no major bleeding being occurred and the patient having an eventful recovery. With regards to the efficacy and the safety of endoscopic stricturotomy and stricturoplasty in the management of the IBD strictures, limited data are currently available. However, accumulated evidence suggests that for short strictures, both techniques are more effective than balloon dilations with a lower risk for procedure-associated perforation. Nevertheless, they are more technically demanding and carry higher risk for procedural bleeding that we cannot overcome. In our department, we currently favor their use in treating short, non-angulated strictures with severe fibrosis or for distal non-angulated always bowel strictures, as they are more technically demanding procedures. For wrongly refractory or recurrent strictures requiring repeat dilations, the above-mentioned modalities cannot be used with endoluminal stents, offering a minimal invasive option for their management. Although to date there is no dedicated type of stents for the management of these strictures, covered self-expanding metallic stents, lumen-opposing stents, and biodegradable stents have been used with promising results. However, the inherent limitation of all endoluminal stents, including migration, malfunction, or hypergranulation, as it occurs in the case of biodegradable stents, decreased their overall popularity. Except for the management of IBD-related strictures, the second area in which therapeutic endoscopy could have a role lies in the management of disease-related fistulas and abscesses. We all know that fistulas and abscesses are well-known penetrating adverse events that we can often see as a result in IBD patients as a result of the long-term disease process due to the chronic inflammation and are often preceded by strictures. For these cases, the main goals of the endoscopic therapy are to drain the abscess, to heal the fistula, and prevent branching of a simple fistula without making it into a complex one. To date, several modalities have been used in order to help clinicians to achieve their treatment goals, but the selection depends mainly on whether an abscess coexists with a fistula or not. More specifically, in the absence of an abscess, endoscopic fistulotomy may be used for the management of fistulas. This modality involves the incision and opening of the fistula tract to the bowel lumen or skin, preventing fistula branching and abscess formation. To date, it has been attempted in several selected patients, such as those with short, superficial, ileocecal, perianal, or pouch-to-pouch fistulas, with promising results, depicting mostly a potential group of candidates for future application of this method. However, when an abscess is present, things are slightly different. It is the location that will determine the method that will be followed in the management of this complication. For perianal abscesses, this is a technique that we use in our department. Endoscopic septum placement can offer an effective treatment option in an effort to avoid surgical intervention. These techniques practically involves the identification of the perianal fistula tract with a soft tip guide wire, endoscopic securing of the tip of the guide wire, and introduction of the seton, which is tied to the tip of the guide wire. But for abscesses located intra-abdominally, the procedure is different. Symptoms are not of value, and drainage can be attempted in this situation endoscopically with introduction of pigtail stents, such as the one that we use in ERCP, through bowel defects that we create with electroincision, as shown in this picture. Other than the above-mentioned areas, endoscopic therapy can be additionally considered for the management of IBD surgery-associated complications, helping patients to avoid, at the end of the day, an additional operation. Among the different postoperative complications, the main complications that can be managed endoscopically are mainly two: the postoperative strictures and leaks. With regards to the management of postoperative strictures, endoscopic therapy generally involves the same techniques with the same limitation as those employed in the treatment of primary strictures. However, when balloon dilation was compared to endoscopic stricturotomy or stricturoplasty, in a case control study of 185 patients who were analyzed retrospectively, it was shown that stricturotomy was by far more effective than balloon dilation, promoting its selection for the management of this type of strictures. However, its final positioning in the treatment algorithm of postoperative strictures was recently established following the publication of a retrospective study that compared endoscopic stricturotomy surgery. In this study, by analyzing the data of 182 Crohn's disease patients with ileocolonic and anastomotic strictures, the author concluded that stricturotomy achieved comparable surgery-free survival with a decreased morbidity compared to second surgery. These findings highlight an overall favorable efficacy and safety profile for endoscopic stricturotomy compared to all other available modalities. With regard to postoperative leaks, different endoscopic treatment modalities have been described in different reports, with their selection depending on the chronicity of the complication. For acute leaks, endoscopic vacuum-assisted closure therapy is an old friend that can be of particular importance in an effort to avoid another surgical intervention, as it was found that promote healing by 5 distinct mechanisms, including macrodeformation, microdeformation, bacterial clearance, exudate control, and changes in perfusion. So far, this modality was used in the treatment of esophageal, gastric, small bowel, pancreatic, and colorectal defects with success rates above 70%. However, little is known regarding its clinical success in IBD patients with a postoperative leak. In this photo series, you can see all the steps of the procedure that we followed in order to control intra-abdominal sepsis that was developed in one of my IBD patients 3 weeks after undergoing subtotal colectomy for acute severe UC in our department due to the development of an anastomotic leakage that was associated with a large presacral fluid collection that cannot be shown in this picture because I haven't included any CT frames. Typically, endovac therapy is performed with a dedicated device such as endosports, but in our case, this was unavailable. Hence, we created a similar device based on several previously published reports from non-IBD populations that we called kebab technique. In order to create our negative pressure system, we wrapped a sterile gauze around the opening of a nasogastric tube of 18 French. Then we stabilized our creation by wrapping a sterile surgical membrane around the gauze, and the whole creation was further stabilized with a surgical suture 2.0 in size. Subsequently, we perforated the overall creation with a sterile needle so as to mimic the open pore polyurethane sponge of the original device. And then we checked the efficacy of suctioning outside of patient's body with the help of an external suctioning device. Finally, under direct endoscopic vision and over the scope, we gently placed our creation intraluminally and not intralesionally. We connected the other end of the nasogastric tube to a suctioning device. Adequate suctioning was achieved at 180 millimeters of mercury, and we left the whole creation in situ for approximately 7 days, which is the upper limit for leaving one such device within the human body. Patient's condition was gradually improved, whereas the size of the collection was finally reduced with no other complication worthy of note. Alternatively to Entovac, which is mainly preferred for complicated cases, just like the one that I have previously mentioned, for acute leaks that are not associated with fluid collections, the closure of the leak could be attempted with mechanical clips, either we are referring to through the scope or over the scope. Clips doesn't make difference depending, of course, on the size of the leak. In general, acute anastomotic leaks shouldn't be left untreated for a long time, since over time they can become chronic, leading to the formation of sinuses, which can further cause sepsis. This commonly occurs and expected after ileal pouch anal anastomosis or colorectal anastomosis. For these cases, a novel approach that is evolution of a similar surgical technique is suggested to be used. It is called sinusotomy. In this technique, we mainly incise the bowel wall that exists between the sinus and the bowel lumen, and the incorporation, and with this way, the whole sinus is incorporated into the bowel lumen. Compared to surgery, sinusotomy has been found to have moderate effectiveness with similar recurrence-free and surgical-free survival, but with a more favorable safety profile. And before finishing my presentation, the final area in the management of IBD where endoscopic therapy can consider is the area of management of colitis-associated neoplasia. In this area, two are the main endoscopic modalities that we currently use: is endoscopic mucosal resection and endoscopic submucosal dissection. It's at least sacrilege to refer to these techniques in a Japanese conference. But the only thing that I can say, which is in line with Yutaka Saito opinion regarding those two endoscopic techniques, for these modalities, current evidence suggests that neoplasia resection is safe and feasible for most IBD patients and should be performed. However, these results stem from studies that were limited by the small sample size and are not then ideal for drawing safe conclusions. However, one is for sure, that if an endoscopist around the world decides to resect a neoplastic lesions, he or she must be sure that the lesion will be completely excised. In summary, basing on the above mentioned evidence, we quote that in 2022, there is a plethora of modalities available in our armamentarium of the therapeutic endoscopy that we can use in order to offer multiple minimally invasive solutions to our IBD patients. However, the application of these modalities should be always made in discussion with IBD physicians and surgeons in order to assure the optimal outcome for all of our patients. I would like to thank you all for your attention, and I'm happy to take your questions.
Dear Kostas, Dr. Argyriou, thank you very much for this wonderful presentation. If you could also stop sharing your screen. And I think we just have a time slot for one question. Dr. Fujiyoshi, are you thinking of anything you would like to ask?
Yes, first of all, I would like to congratulate Professor Costas for the very interesting lecture on the endoscopic management in IBD. I just have one question. So to prevent post-ESD stenosis, injection of triamcinolone has been utilized. What is your opinion on the use of corticosteroids or anti-TNF as topical injections in IBD patients with strictures?
When it comes to IBD, the data are not really conclusive. We have only data from small case series showing contradicting results. Definitely, the European Society for the Management of IBD doesn't currently recommend the use of steroids in the endoscopic management of this patient, especially when we deal with the management of the strictures. However, I am in favor of using IDTNF not only for the pharmacological management of strictures, but also for fistulas as well, where preliminary data have shown that it might be of value in cases where underlying inflammation exists. And we all know that when it comes to IBD patients, there is always an inflammatory component, even when we talk about strictures, even when we talk about fistulas. There are many unanswered questions so far as for the ideal dose of the anti-TNF that we can use, but the most important question and the most important problem that we have to resolve, I don't know whether Professor Grover used it in USA, but in Greece, when it comes to triamcinolone, it's not available. But when it comes to anti-TNF, we don't have the official approval of the pharmacy to, in a way, allow me to say, to give it in a different way that the one that is supposed and approved to be administered.
I'll add on that for injectional anti-TNF, we have used it for pyoderma gangrenosum for injection topically, but we've not used it endoscopically for strictures for the reasons that Dr. Argyrio has mentioned that exist in Europe. The same conditions exist in North America.
Is there any exact dose that you prefer? Do you prefer to inject 10 milligrams of infliximab or 40 milligrams of infliximab or any other dose that you use even in the case of pyoderma gangrenosum? Because so far I haven't had the opportunity to administer it for this type of complication.
To be honest, I don't think there is any consensus on the dosage of infliximab to be used. To be honest, I rely on the dermatologist to provide with the dosage advice with respect to it.
Thank you very much.
So thank you all. I think it's time that we close the session. But before doing that, I'd like to thank each and every one of you for contributing to the success of this session. I really enjoyed it. Both speakers did a great job. So I thank you from the bottom of my heart, and I speak for my co-chair, Reina Fujiyoshi, and on behalf of Professor Inoue and the rest of the organizing committee, when I say that we really enjoyed this unique IBD session within the Tokyolive Endoscopy 1 of 2022. So thank you all, take care and enjoy the rest of the Tokyolive. Thank you.